Morning, guys. The topic for today is pain science, and this is going to be seminar 3 or week 3 of functional movement So what can we say about how do we want to break down the understanding of pain science? I think the first thing is to classify pain into 4 broad categories. So the 4 broad categories are 1, nociceptive pain. 2, inflammatory pain. 3, neuropathic pain. 4, which is probably the most difficult to conceptualize, is central pain. And in terms of a little bit of a basic understanding, nociceptive means that, well, a nociceptor is a receptor that transmits a sensory signal. Okay, so it's just a receptor in any part of your body. The receptor may be in your skin, in your viscera, or your organs such as your bowel, bladder, intestines. It could be in our joints and our discs, spinal discs. All right. So a receptor that then receives some sort of sensory stimulation and it then transmits that signal to the brain. So common examples may be stretch. Actually, I'll just put that in. So common examples may be stretch, the sensation of stretching, heat, sharp, heat or cold, sharp sensation, vibration, pressure. Okay. When the stimulation ceases, so when this sensory stimulation stops, there is no further signaling from the receptor to the brain. Okay, that stops as well. All right, so that's a basic understanding of a nociceptor, and that's why we call it nociceptive pain. Okay, so we've talked about nociceptive pain and nociceptors there. Let's now talk a little bit about inflammatory pain. Now, inflammatory pain is mediated not by nociceptors. It's primarily mediated by physiological processes involving white blood cells, such as macrophages, neutrophils, lymphocytes. Okay, so you don't really need to worry about those terms, but realize that those cells will release what we call cytokines, and they promote the features of inflammation that we've all experienced. Okay, things like swelling, heat, redness, which is secondary to blood flow. Okay, so, and how does blood flow occur? It occurs by vasodilation. And then, of course, that all results in tenderness and pain. All right, so that's really what happens in inflammatory pain. So let's go to the next major category of pain, and the next one that's really probably the simplest to understand is neuropathic pain. So let's do this in yellow, because traditionally nerves are always coloured yellow. So in our nervous system is made up of the brain stem, our spinal cord, and then our peripheral nervous system. Okay, so that goes out to the... So this is what we call our PNS, and this is our CNS, including the spinal cord. Now, if there is an injury to a sensory nerve, so if we injure a sensory nerve, then we can experience neuropathic pain. So the most common way of injuring a sensory nerve is through, as many of our patients will experience, is through a disc prolapse. So here's a cross section of a spinal vertebra. Okay, so these are the little wings, and then the disc lives in here. Okay. Now, a spinal disc prolapse is when part of the disc herniates out like that, and irritates the nerve right here. Okay, and so that's called inflammatory. That's called neuropathic pain. because it's irritating sensory nerves which lie within this trunk nerve root. Now, I'll explain it a little bit later, but just remember that there's often overlapping elements of these 4 types of pain. After this nerve is injured by the disc prolapse causing neuropathic pain, it isn't unusual to also get inflammation occurring there. So you can have 2 elements of pain going at once. So you have the neuropathic element, and you have the inflammatory element all going simultaneously. And the facet joint, for instance, say the nerve injury is causing some dysfunctional movement, and you're not moving your spine correctly, and that may then start to cause some nociceptive firing of the nociceptors within the facet joints, and the facet joint lives over here. Okay, so now we then start to get some nociceptive pain as well. Nociceptive pain coming from this facet joint, and he then becomes inflamed secondary to ongoing poor movement. So now we have a condition where there's inflammation here, there's inflammation here. Oops. There's nociceptive pain here, and neuropathic pain here. And so you can see that in one process there's 3 different types of pain that are active. Okay, so that's neuropathic pain. You can have lesions or multiple sclerosis. Those are other types of conditions that can knock off parts of the central nervous system, and these can be rare causes of neuropathic pain as well. Okay, so they're rare causes. The last classification of pain is the central pain. Now, central pain is the hardest to conceptualize, but the important characteristics of central pain is that it's a hypersensitivity, okay, it's variable in onset. It takes time to develop. It's maladaptive. Okay, maladaptive as opposed to adaptive. Okay, adaptive, where adaptive pain helps the organism, helps the individual. To recover. Okay, so if you have nociceptive pain and something sharp, you sense this, your nociceptor tells you that something's sharp or hot, you will then pull away from it. Okay, and you won't repeat it. You won't do that again. And that's what we mean by adaptive. Whereas maladaptive, it does not help. It does not help you recover. So someone who is centralized with their pain is responding unhelpfully towards recovery. So in order for someone to break out of their centralized pain, the process of centralization actually has to be eliminated. Eliminate central processes in conjunction with the original cause. You can't just target the original cause, because this centralized pain will obstruct you from fixing the actual originating cause. So let's give a few examples of a centralized process, some non-pain related examples. So just say, for instance, someone who is hypersensitive to spiders. Okay. In a sense, it's normal to feel apprehensive, cautious about spiders. Okay. And you might take action, go and get the morphine. All right. But someone who has a centralized process to spiders will hyperventilate, run around, scream, jump out of a car or something like that. Okay, because they are so hypersensitive to this process, this exposure, the spiders. There are many other types of examples. Anxiety is a type of centralized maladaptive response. Depression. Okay. And of course, pain, which is what we're focusing on here today. But if you think about the way people might respond to situations or social situations or life situations, these are a form of hypersensitivity, and they represent a centralized process. Okay. So specifically in relation to pain, let's make it clear and understand this really, really well. So if for instance you had an injury to your foot with something heavy hitting your foot, and it really damaged your foot such that it was really mangled up. Okay. And then time passed, maybe months or years, and then you had this mangy foot, and it was constantly painful. What happens in the central nervous system is that these other three mechanisms of pain have been relaying signals to the brain. Okay, nociceptive, inflammatory. Inflammation probably calms down after a little while. And neuropathic. Okay, so they're transmitting these signals to the central nervous system, and after a variable period, as we said, we start to get little changes in the central nervous system, in different parts of the central nervous system, and those physiological changes really are represented simply by the way that the nerves are talking to each other. Okay, so nerves have to talk to each other, and these centres that regulate and control our understanding and perception of pain become abnormal. Okay, and we can refer to that just as a tangled up neurophysiology, just like a tangled ball of string, tangled knots in your nervous system. They're not meant to be there. Okay, and if once these little tangles in your nervous system active, you now have centralized pain. Okay, and a lot of people who experience pain for a long time, and that's why people who have chronic pain have to be managed differently to people who have acute pain, because people who have acute pain have not yet developed these little tangles in their nervous system. So if this person with this mangled foot says to his orthopedic surgeon, I have terrible foot pain, my brain is telling me I've got terrible foot pain, please amputate my foot. Okay, so we remove the foot altogether. That eliminates all of this abnormality down here, and he's left with a stump. You can see then that regardless of the surgery removing the original source of the pain, as we said earlier, just removing the original source is not going to fix the problem, because he still has these things active in the brain. Okay, and the exact same situation arises in someone who has had pain for months or years in their spine, and we might, as surgeons, recognize some inflammation in the disc. We might recognize some little nociceptive activity there, maybe a little annular tear. Okay, we might recognize some discitis, and over here we might see some a facet joint. We might see some facet joint arthritis here, and I'm sure many people have had cortisone injections applied into these structures. Okay, injections, and they may have had epidurals. Epidurals is very common. they may be taking a host of drugs such as anti-inflammatories, endone, Tarjan, Panadol, Nurofen, Mobic, Celebrex, they're all the common ones. And it really is ineffective. It doesn't work. Ineffective because even though this may be the originating cause of their pain, once they've had it for a very long time, the pain is locked in. Here's the brain again. The pain is locked in up here in the central nervous system, and no matter what you do out here, we can't eliminate these processes by doing these things. And surgery, say we operate on this patient, it's just like the patient with the mangled foot, that we amputated the foot. If we do a fusion, if we perform a fusion and put some screws in like that, that still does zero. It does absolutely nothing for these centralized processes that are active in the brain. So that is the important distinction about centralized pain. And in order to eliminate centralized pain, in order for those little tangles, we can call them neural, physiological tangles to unwind, we have to remove the threat. We have to remove the threat. And in terms of the musculoskeletal system, the threat is poor movement. Okay, so of course when someone is in pain, they're going to move poorly. Pain makes you move poorly. Think about going for a walk. Imagine trying to go for a walk. Try walking with a stone in your shoe. Okay. The pressure of the stone on the sole of your foot is going to create this dysfunctional gait, dysfunctional walking, and it's going to cause pain. And so we need to eliminate the movement dysfunction that is continuing to drive the central nervous system cautionary signal that exists. And it is extremely difficult once people become centralized. It's not impossible, because if we eliminate all threats, okay, if we remove all threats to the organism, to the individual, okay, so that means we're moving well. Obviously, control inflammation, control nociception, control neuropathic pain as best we can, and there's a host of different mechanisms to do that. Then spontaneous, slow, steady untangling can occur. Okay, and in order to do that, this is really a big part of where functional movement therapy plays a huge role. Okay, and that's the NeuroHab program. Okay, and that's why it's so important. And it's also important to try to get patients early. Alright, because if we don't get patients early enough, they're chronic, or they're relapsing, so they get better, then they get worse, so they have this relapsing remitting pattern. Their movement is poor, their movement is worse because they've developed all these compensatory movements, compensations, and most importantly, centralization has developed. Okay, so that's a sort of nutshell understanding of pain and where movement really is why movement therapy plays a key role in recovering from back pain. And so we've got nociceptive, inflammatory, neuropathic, and then central. And they can all overlap one another. Okay, so you can have a little bit of this, a little bit of this, a little bit of this, some of this, or it may be very little, or it may be mostly this and hardly any of this and hardly any of this and none of that. No, and zero neuropathic. Okay, but in most scenarios it's a combination of 1, 2, 3, and 4. Okay, if there's any questions about that, feel free to comment and ask our team to help explain it further and really understand the pain physiology. It's not too hard when you think about it a little bit. Okay.